Next topic would be covered by Dr. Sanjiv Patil. So he will speak on cooperative surgery, the new kid on the block. Dr. Patil, please.
A very good morning to one and all. First of all, I would like to thank the organizers for, please run the video. Organize for giving me this opportunity. So today I'll be presenting a video on endolaparoscopic cooperative surgery, the new kid on the block. So this is coming up in a big way. The advantages of both endoscopy and laparoscopy will particularly help in some subsets of patients where you can do an organ preserving surgery. That is the main idea behind this procedure, and especially patients who have subepithelial lesions, like in this particular case which I am presenting, there was a case, this was a case of a pre-pyloric tumor, and here a sleeve gastrectomy would not be possible because it would cause gastric outlet obstruction. So in such case, the only option would be to do a distal gastrectomy. In this case, what we can do is endoscopically you can give a submucosal injection and elevate the lesion, and then you can give a seromuscular incision laparoscopically, and then you can staple on the mucosa so that there is no luminal narrowing. So this is the basic idea of this procedure, but this can be used in various other areas as well, because subepithelial lesions of the upper GI tract are usually have very low malignant potential. So you can go ahead with a local resection because the chances of lymph node metastasis are also very less. This procedure can be applied in esophagus, especially leiomyomas which are big, where a esophagectomy can be avoided. Lesions at the GE junction, especially gastrointestinal stromal tumors, where a total gastrectomy may be avoided. And in this particular video which I am presenting, a pre-pyloric lesion where a distal gastrectomy can be avoided. And in first and second part of the duodenum, especially neuroendocrine tumors which are little big, then they may end up in Whipple's. So you can avoid even a Whipple's procedure. So that is the basic idea of this procedure, but this is evolving. So we have done about 40 to 50 cases of them at our institute. In this particular case, this gentleman presented with history of GI bleed, and on evaluation was found to have a gist in the pre-pyloric region, quite big, approximately around 4 to 5 centimeters. So we decided to go ahead and do a sleeve gastrectomy in this patient. So we are bearing the greater curvature of the stomach of all its attachments, both omental as well as vascular. So we are using a Thunderbeat here, which has a combination of both ultrasonic as well as bipolar, that is helpful to have a good hemostatic division of the greater curvature of the stomach. So especially the subepithelial lesions of the esophagus, stomach and duodenum, that is upper GI tract, usually the neuroendocrine tumors, lipomas, gastrointestinal stromal tumors and various other lesions usually have a very low malignant potential, and the lymph node metastasis also is very less. So these patients have to be evaluated thoroughly before going ahead with this local resection to rule out any nodal metastasis. If that is there, then these procedures are contraindicated. So the whole of the greater curvature of the stomach is bared now. So once the greater curvature of the stomach is bared, you can see the lesion clearly now, quite big, and as planned we went ahead and tried to do a sleeve gastrectomy using a stapler. But as you can appreciate here, you can see the first part of the duodenum and the pyloric area, there was significant narrowing there. We did a on-table endoscopy to see whether we can get away with a sleeve gastrectomy, but on endoscopy we were sure that it would cause narrowing of the antrum. So on confirming this, then we decided to go ahead with this endolaparoscopic procedure. So you can see here a good umbilicated lesion there. Endoscopic submucosal injection is given here all around the tumor. The most important thing here is to give a liberal quantity of submucosal injection so that there is a good cushion between the mucosa and the tumor. Later you will understand why. So obviously a good expertise is required endoscopically, because it is not as simple as doing endoscopy, because the patient will be undergoing laparoscopy as well simultaneously in an odd position. So expert endoscopist is required to go ahead with this procedure, as well as injecting all around the tumor is also a challenging thing. So once we do that, we are going ahead with seromuscular incision all around the tumor. Various energy sources can be used for this. So the space between the tumor and the mucosa is the critical thing here to avoid inadvertent injury to the mucosa. As you saw in the picture, it was an umbilicated lesion and mucosa was ulcerated at that part. So if required, again you can give some more submucosal injections again endoscopically to aid dissection. So you can see here it can be swept off comfortably after a good submucosal injection. So we have added methylene blue so that it can be appreciated well, and you continue the serosal incision on all sides. Sometimes a monopolar also will be handy, in the sense angulation sometimes may not be good for using a thunderbeat or a harmonic. So in such cases, and you can see here the submucosa that lose areolar tissue just with a burst of the cautery gets separated easily. So this is how the seromuscular incision is continued. And one important thing which is to be appreciated here is the non-active blade should be towards the mucosa and the active blade towards the serosa to avoid the mucosal injury. So once the serosal incision is complete, a stapler is again fired on the mucosa. Once the stapler is applied, again an on-table endoscopy is done to ascertain that the lumen is not compromised, and the stapler is fired. You can see the endoscopic vision of the same. You can see the staple line posteriorly, the dotted line, and now on insufflation you can see there is, and the other advantages you can even see that there is no air leak here, and the lumen is not, and this is the end result of it. You can see the amount of serosa that is being spared, and finally interpreted sutures are taken on the serosa. So this is how you can do organ preserving surgeries in various areas for these tumors, and all the centers may not be having the expertise of a good endoscopist and an on-table endoscopy. So over the period of these 2-3 years where we have done a lot of cases, we are trying to do, in this particular case we have tried to do a submucosal laparoscopic injection using a IV cannula, that is a Venflam that was used in this particular case, so that on-table endoscopy could be avoided in, not in all cases, in few cases. So the same procedure laparoscopically here. The seromuscular incision is continued all around, and again the stapler is fired. This is to try and avoid using endoscopy on table. And you can see the staple line, the amount of serosa that is being spared on the specimen, the endoscopic view of the staple line. Almost about 1 to 2 centimeters on either sides of the staple line. But the disadvantages of this that we felt over a period of time we have evolved, every time you need to inject and again cut, you will have to repeatedly change the instruments. If you are using, the video is not running. No, it's running. So if you have to use the multiple times, you have to change the instruments to inject and again use a cautery or a energy source. So we tried to use the aspiration needle to both inject as well as use a monopolar cautery to give this seromuscular incision. But the disadvantage of this is usually the ones which are available in the market are wide bore. approximately around 18 gauge needles. So you can see the amount of spillage of the dye in the peritoneum. So this was one disadvantage that we felt using this aspiration needle for the both injection as well as giving a seromuscular incision, but this was definitely faster than the previous thing. Using this together hastens the surgery. The time required would be obviously significantly less. This is how we tried in few cases. And now the speedboat which is come in poem, usually the advantage of it is the same, injecting and using a monopolar cautery in the same. So this was one modification, customized modification that we have done and named it as a speedboat. The tip of the needle was customized to decrease the caliber of the needle so that there is no significant extravasation of the dye. As you can see here, this is a modified needle that we are using now, and we are very happy with the results with this. There is a good submucosal. Usually with the tip of this fine needle, you can give a small incision on the seromuscular layer and then inject through it with a small caliber needle and then go ahead and do a seromuscular incision using a monopolar cautery. So we have found over a period of time with evolution that first we used to use this, but the advantage again we had to change the instruments every time. We needed to inject approximately 20 to 30 times. Then we started using this regular thing which is available in the market, but the disadvantages I have already showed you that there was. Now this was the modification that was done. The caliber of that was reduced in our institute only, and then we have tried to use this, and it has worked to good effect. So these small changes, though may appear simple, but they are very, very important, because as you can see in this particular case, just a needle of the tip of the needle was changed and the timing of surgery has significantly come down, and we are very happy with this. So most of these ideas are given by my mentor Dr. G.V. Rao, who is here. So though they appear very simple, but they are very, very important. So that is how a procedure should evolve, and thank you so much. Any questions?
Excellent presentation.
Thank you, sir.
Just one or two couple of comments that some of these tumors can be managed by stir technique.
Yes.
So what decides whether you will go for stir or you will go for a combined or a cooperative endoscopy as you're talking? Is it the size? Is it the extramural component which will decide? Because I'm sure knowing AIG and knowing your endoscopy skills at AIG, some of them can be managed by endoscopy alone.
Yes, yes, yes. So definitely the size is very important, because beyond a particular time even stir would be very difficult, and the location of the tumor as well. If involvement of the mucosa as well as size of the lesion.
So I think size and the extramural component I can agree to, but for entrum I think that's one of the easiest size to do the stir.
Yes, yes, yes.
Dr. Sanjiv, hi.
Yeah.
I think beautiful videos.
Thank you.
Just a couple of questions. I think this is basically the evolution from the concept of the clean net procedure that we used for early gastric cancers.
Correct.
This injection of the dye was basically done because the tumor wasn't, the location is not obvious when we do it laparoscopically.
Correct.
It's when we inject the dye for the margins.
Yeah, that is one thing, and or if the tumor is big enough, and in that particular case we can give a subserosal laparoscopy injection. Endoscopy may not be required.
My question is, when the tumor is very obvious and we are not talking about a adenocarcinoma, where margins are not a concern, why the really need of a dye injection? Because we have the tumor in hand, we know where the margins are, we can actually get into seromuscular dissection and go through the whole area without actually having the injection.
If you are injecting a dye, then there is a space between the mucosa and the tumor, so that any energy source you can use liberally, so that the damage to the mucosa is not there. That is one advantage. And the other advantage is you can spare a bit of serosa. The serosal incision can be on the tumor side rather than on the normal stomach side, so that the luminal compromise is less if you give a submucosal injection.
Okay, thank you.
Dipankar Mukherjee from UK. My question is, actually I agree with the technique and I have used it myself, but I think Dr. Goenka briefly was going to touch upon this. In an ulcerated tumor, one has to be very careful.
Sure,
because if you have got a mucosal breach, if you don't have a mucosal breach, I have done it for GEJ, gastroesophageal junction GIST, which are non-ulcerated with a large exophytic component. And in that situation, these are ideal techniques. But you saw one where there is an ulcer. And I
Yeah.
just say that, you have to be careful about if there is a breach in the mucosa.
Yes. See, if there is ulcer and this particular case that I presented, you dissect all around till you reach the ulcer. You don't go beyond and open the mucosa and staple just as you reach the ulcer, so that you don't breach
We
the...
have been using this technique, but not in ulcerated tumors, because sometimes it can be quite difficult.
No, but as you saw in the video, it was convincing that we can avoid any mucosal breach even if there is an ulcer.
Yeah, I just have a question. Combined endoscopic laparoscopic procedures are well known in colorectal surgery for
Yes.
large polyps and even T1 cancers.
Yes.
So why not just do a full thickness resection endoscopically and just suture? You are suturing the serosa anyway.
No. Yeah,
So what's the harm in doing a full thickness resection?
Full thickness resection
You get
can
a-
be done laparoscopically.
Yeah, and then you're suturing anyway. You're doing a laparoscopic suturing anyway, so you can do a full thickness suturing.
In particular subset of patients, what you are advising is right, but if you are resecting the full thickness, then you will have to, in this particular case where the tumor is in the muscular, you can spare, not in all cases, but
Many times you're not aware if you have a high grade gist, then you need a adequate margin, and just the way you are removing it might not be adequate.
yes. So
oncologically.
particularly
And you're suturing, you're doing laparoscopic suturing anyway.
Yes, we are
So
doing
I-
laparoscopic suturing.
Yeah, so
The
you
other
can do
thing
a
is the
full thickness suturing.
contamination can be avoided by avoiding a full thickness incision on the stomach or
But
whatever.
you would be compromising on margins if you have a high grade tumor.
If it is, these procedures
How
are
will you know that
definitely,
preoperatively?
a good evaluation is required, and for example, if it is a gist, a good endosono, if required a biopsy to see what is the grade of the tumor, whether there are lymph node matters, all this has to be done before going ahead with this conservative procedures.
I'm Dr. Jyoti from Chandigarh. Nice presentation, sir.
Thank you.
How we infrequently we may get some histological surprise, especially in case of emergency settings when patient comes with bleeding and we get gist-like picture, and if we get histological surprise of adenocarcinoma, then how will we proceed
No,
with
see,
managing
first
this case?
thing is you have to be very,
It's
very,
rare, but yes.
yeah, you have to be very, very clear what is the diagnosis on, suppose even after evaluating the patient thoroughly and then you get a histological surprise, then definitely you have to go in and advise the patient would require a radical resection. If it comes out to be an adenocarcinoma, which is very unlikely after a good evaluation, but if it happens by any chance, then you will have to advise the patient to go ahead and for a gastrectomy, radical gastrectomy.
A last comment from my department actually. This is more a presentation to show that actually the surgeon should get actively involved into endoscopy. If we have done this procedure in my department, it is obviously filtered through the gastroenterology department and come to us. So there are some cases which cannot be done endoscopically. There are some cases which can be done only through cooperative surgery. So the message is very, very clear that I think we should have some endoscopy component in the surgical gastroenterology. Otherwise, we'll miss this race with the gastroenterologists.
Hello.
Yes.
Hello. No, I think Dr. G.V. Rao made the most important comment that we are not, as surgeons, we tend to be more attracted with laparoscopy, robotic, and we are letting the endoscope slip out of our hands.
Correct.
I think it is time we started using this and adding it to our techniques. This is a big mistake we are making. It's good to see that people are not using the endoscope in a more constructive manner.
Correct.
That's why, exactly, that's why I wanted to say the process is on. More than 2,000 surgeons are trained of basic things. We are not going to compete with Professor Mahesh Goenka, but this is a good beginning and we should encourage it.
Sir, again, one comment. We are not competing with the gastroenterologists.
Yes,
We are
absolutely.
doing this endoscopy in the operation theatre. I am not doing this for my survival. I am doing it for the survival of the patient. So I am not doing this endoscopy outside the operating room.
Absolutely, absolutely agree. Thanks a lot, please.
Thank you, thank you.
Thanks.